Hi, everyone. It's a pleasure to introduce our next three panelists for this session on precision power. We have Dr. Zagopoulos, who is a surgeon scientist with a translational research program on the genetics and oncogenomics of pancreatic biliary cancers. His clinical practice focuses on the surgical treatment of pancreatic, biliary, and hepatic malignancies. Dr. Zagopoulos' leadership roles include co-chair of the Pancreatic Disease-Oriented Group of the Canadian Cancer Trials Group, director of the Cancer Research Society, and executive member of the Pancreatic Cancer Early Detection Consortium, also known as PRECEDE. Alongside Dr. Zagopoulos, we also have Dr. Rodney Willett, who is the founder of the Atlantic Canada Research Institute in Moncton, New Brunswick. He holds the R.R. Ledger Chair in Precision Cancer Research. He also serves as the medical director of the Molecular Genetics and Sequencing Laboratory at the Dr. Georges L. Dumont University Hospital. Dr. Willett leads multiple projects applying multiomics to liquid biopsy and using AI to improve cancer outcomes. He has served in leadership roles with the New Brunswick Health Research Foundation, the New Brunswick Innovation Foundation, and Prostate Cancer Canada's Research Advisory Board. And last but not least, in person with you, you should have Dr. Orchun Hatcheries, who completed his PhD at McGill University, where he focused on multi-omics computation to elucidate complex host microbiome interactions. Dr. Hatcheries joined Dr. Broad's lab at the Research Institute of the McGill University Health Center in 2022 to begin a postdoctoral fellowship, during which he uncovered mediators of PDAC initiation using RNA-seq and plasma exosome analysis for biomarker discovery. To date, his work has resulted in an impressive 22 scientific articles with nearly 1,500 citations. So please give a warm welcome to our speakers, and I look forward to the session.
Good afternoon, everyone. Could you hear me?
Yeah.
Jessica, could you hear me?
I can hear you, but maybe someone can confirm that they can also hear you in person.
Yeah, we can hear. Can you hear us?
Thank you very much for the invitation. And I'm sorry that I'm not able to join you in person. And I will not be able to look at you. I don't have two screens set up in my office off my laptop. So I've projected my slides, and hopefully you could see my slides. What I thought I would provide is maybe a little bit of a teaser for a conversation on biomarker guided pancreatic cancer care with a focus on genomic medicine. So I don't have any disclosures other than to thank you for this opportunity to present at your national conference. So we all know this, and this is why we're gathered here today. Pancreas adenocarcinoma, or the most common type being ductal adenocarcinoma, is quite difficult to diagnose. It's most often diagnosed late and extremely difficult to treat. We have not found one empiric one-size-fits-all therapy that works effectively for pancreas adenocarcinoma. And what is striking is if we look at these SEER data from 2024, where they did the comparison and they looked at the evolution of mortality across cancers over the last nearly a century now, you could see that there was a spike in many common cancers, and then we're seeing an overall decline over time as effective treatments have become more evident. But little improvement for pancreas cancer. You could see this with this orange line here. It's pretty much a flat line. This is for males on top, all the way from the 1930s to 2022 or 23 when this was censored, and the same thing for females. I mean, we've made important progress surgically where we could do the operation surgically, but this tells you the fact that, the flat line remains, is that this is more of a systemic disease. So the disease at its very early stages spreads unless you catch it at an extremely early stage, in the stage 1, where it's at the very beginning. So how do we improve survival for pancreas cancer? And there's been a lot of effort recently in early detection. Why? Because if we have a very early cancer, or even better, a precancerous high risk growth in the pancreas, and we intervene surgically, well, the high risk precancerous growth, surgical intervention would be 100% cure. But a stage one, a very small tumor, if we could catch it, which is not easy to do, it actually represents a bit less than 5% of all pancreas cancers that are diagnosed are stage 1A. But if we do catch a stage 1A, then the 5-year overall survival is 80% rather than 13%, 10 to 13%, which is what it is across all stages. So early detection is one approach. The other approach is to maybe identify better therapies against this cancer. And we have used the one size fits all, tried number of therapies over the years. The more recent combination therapies work better, but nonetheless, they remain not as effective as we'd like them to be, because our mortality from pancreas cancer still remains quite high, with a 5-year overall survival of 10 to 13%. And I put this up. This is a trial led by Malcolm Moore at Princess Margaret in Toronto, and this was when I was a resident in 2007, and when it came out. And clinically, did it mean much? Not really. 10 days difference in overall survival. It was statistically significant, but it did not perhaps mean as much clinically. But what was interesting is that, this was probably, I would say, in pancreas cancer, the first maybe biomarker trial. Although it was not biomarker informed at the time, it was targeting, a molecule rather than being cytotoxic in some other way. And now current efforts are to find patients that may be more receptive to this anti-EGFR, drug, because they may not have a KRAS mutation, for example, so they may be responsive to. But I just put this up to show that, we in Canada have been thinking about biomarker-informed treatments for pancreas cancer for a few decades now. What have we learned over the last 15 to 20 years? We've learned a lot of biology. I would say with the explosion of technology, the ability, the human genome was sequenced and became available in the early 2000s, and technology for primarily genomic medicine and other omic and other platforms have also come into the research space more recently. There's been an explosion of this technology, and it's been applied, and we've learned a fair bit about pancreas cancer. We've learned what the initial events are. We know that 90% of pancreas cancers will have this initiating mutation called the KRAS mutation, and then it's pretty indolent for some time up until other mutations like this CDKN2A mutation happen, or SMAD4 mutation happen, a P53 mutation happen, and the cancer it forms. So you go from a very early indolent, not very invasive cell to a much more invasive transformation that happens over time. So there are two ways that a pancreas cancer may develop. One is through a solid lesion, and the other one is through a cystic lesion. And these cysts are very, very common. By the age of 80, 40% of us will have a cyst in our pancreas. And what's interesting here is patients with a family history or a genetic predisposition of pancreas cancer, we think, have a higher incidence of cysts. So, this KRAS will be an initiating event in both the solid formation of a pancreas cancer, as well as in a cystic formation. And what I'm showing here are two ways that pancreas cancer at a molecular level is now broadly classified. And we think this may have both prognosticating implications as well as response to the mainstay therapies that we use for pancreas cancer may may be informative. And on one end, you have this classical subtype, which is a much more favorable subtype. And on the other end, you have this basal-like subtype, which is much more aggressive. And nothing is really lives in a dichotomy. There is a hybrid subtype in the middle. So this is a lot of this work has happened, and we're beginning to molecularly classify pancreas cancer by understanding biology and regrouping the molecular classification changes into subtypes of pancreas cancer towards trying to get more tailored therapies for pancreas cancer. Here on this side of the slide, I put together the COMPASS trial, which is a Canadian-led trial from Princess Margaret and the OICR, and many of us contributed to it as well. And the final results of the trial were published. This was a prospective trial where patients with advanced disease, metastatic or locally advanced disease, got biopsies and then went on to therapy. So they did not have they had not seen chemotherapy when they got the biopsy. And we were able to go ahead and profile, do whole genome sequencing and whole RNA sequencing and learn a fair bit of biology by doing this. And in some cases, we were able to inform how the patients had treatments after they progressed on the first line of therapy. But simply to say that, technology is there, and not only could we use these advances in technology to understand biology, but we're starting to apply them clinically towards making decisions for patients. So how could we individualize care? So what are the strategies that we could use? So I like to think about it in two ways. One is germline, so the hereditary component, and the profiling that we could do for the tumor. So germline testing, so if we test and see if we have a mutation that gives us an increased risk for pancreas cancer, well, it will help our family members, but it will also help us if we're diagnosed with a pancreas cancer, and I'll show you why. So a germline mutation is not only important for the family, but it may also inform treatment for the patient that has just undergone a germline test and been done after their diagnosis with pancreas cancer. And of course, if you profile the tumor from the patient, the pancreas cancer from the patient, and you identify molecular changes, perhaps we could target those molecular changes and have a more effective therapy that's much more tailored and individualized to the patient. So I'll take a step back and we'll look at these two concepts separately. First, germline testing. We said it's to help inform treatment for the patient that was affected with pancreas cancer, and also to potentially help their relatives in preventative strategies. So in 2019, the recommendation came out that everyone with a pancreas cancer diagnosis should have germline testing. It should be universal. We should no longer identify patients for germline testing based on their family history of pancreas cancer or not, regardless if they're younger or older, and regardless of stage. Everyone should have a germline test. And maybe we could discuss at the end how we're doing in Canada in offering patients germline testing when they're diagnosed with pancreas cancer. One of the studies that contributed, there was work out of Canada, but one of the bigger studies that contributed to this recommendation by the NCCN was the Memorial Sloan Kettering Impact Study, where they found 17% of patients had a germline mutation. So they looked at over 1,000 patients, just over 1,000 patients, and they looked at 100 genes that are involved in cancer predisposition, so hereditary cancers. And they found that 17% of those patients carried a mutation in them. And this served as the backbone to make these recommendations for every patient that we see in clinic with a new diagnosis of pancreas cancer to have germline testing. Of course, these numbers are based on who we see in our clinics. So there will be some referral biases. And in our clinic, there will be population biases in the sense that in the French-Canadian population, there is a so-called founder effect where we may see an increased frequency of certain mutations, particularly in the BRCA2 and 1 genes. So when we applied it, just to share some local data, when we applied it in our clinic, we saw the same number, 17% or so of our patients with a new pancreas cancer diagnosis carried a mutation. The point of this slide is to say that in order to be able to do this effectively, many of us have gone to what we call point of care testing and mainstreaming, rather than identifying the patient in clinic with the pancreas cancer diagnosis and referring them on to medical genetics, which could take in our system could take anywhere from 6 months to 2 years, depending on their priority to be seen by medical genetics. We do the genetic germline testing in clinic. There is a level of pre-counseling that's provided to the patients, and then they go ahead in their primary clinic appointment, when they're either seeing a medical oncologist or a surgeon, they'll have a blood draw and genetic testing. And then we could return the results within 13, we said 13 days here because this was on study before it became provincially covered. With provincial funding now, it's up to 3 weeks. Nonetheless, within 3 weeks, we're able to return the results to the patients. And we and others, I cited another paper that came out at the same time here, believe that this is important because as patients move on in their treatment, they become very focused on their cancer-directed therapy, and this becomes less of a priority for them, and may not get done if it's not done initially. So why germline testing? Germline testing is the prototype for precision oncology in pancreas adenocarcinoma and pancreas cancer. And it has, and the example is BRCA2, BRCA1, and a related gene, which is the partner of BRCA2 called PALB2. So if we have a mutation in one of these genes, it can lead to a pancreas cancer that has an inability to repair DNA effectively. So we could capitalize on that. We could cause more damage using platinum agents, a certain type of chemotherapy, and cause the cancer to be even more mutated. And eventually, by accumulating all of these mutations, all of these breaks in the DNA, the cancer will die. So we take advantage of the inherent problem the cancer has. And what's important about this germline mutation, these types of germline mutations in these 3 genes, is we see it, and this has been consistent across various series that have been reported, anywhere between 5 and 10%. The 10% is seen in series where they have these founder populations where there's recurrent mutations in these genes because of what's called the founder effect in genetics. But it's a significant fraction of patients that are diagnosed with pancreas cancer that carry these mutations, and we could capitalize on this and target their therapies. The other part that's important is that most of these patients that have, so about 90% of the patients that have a germline mutation and get pancreas cancer, their pancreas cancer is the result of the germline mutation. And we know this because if we look in their cancers, they have this phenomenal, these hallmarks of changes in the tumor that are hallmarks of homologous recombination DNA repair deficiency. So that's a type of DNA repair deficiency that happens when there's a mutation in either BRCA2 gene, PALB2, or BRCA1. And if we give these patients, without going through every curve here, if we give these patients platinum and they truly have this homologous recombination deficiency, they will do better. They'll have a better survival because they will respond to treatment better. And this was shown in 2019 by Talia Golan in her trial that was published in New England Journal of Medicine, where she used PARP inhibitors, which also target this pathway, to show that if patients had a good response to a platinum-based chemotherapy, then you could put them on a PARP inhibitor and you can maintain them. You could control their cancer for some time on those inhibitors. So that was really the prototype for precision oncology in pancreas cancer. I'll give you an example. I think this is fun. I always like showing a case at such conferences. So this is a 57-year-old male that presented, was referred to us to see for a new diagnosis of pancreas cancer. And this is a CT scan, and I'll point it out here. You can see these are the arteries, and all of this black part that's surrounding this vessel that's going through the middle of the screen, that's cancer. So that's surrounding the superior mesenteric artery, and that's an inoperable, locally advanced cancer. So every patient that comes in our clinic gets a germline test. We did find this mutation in the patient. Patient goes on to have chemotherapy, and we treated him with 12 cycles, so a full course of chemotherapy. Our protocol has been to give radiotherapy as well after the 12 cycles of chemotherapy. And here we are. So this is what we saw after. And I think what you could appreciate, hopefully, here is around this vessel. I'll play it once more. It's all black. That big, dark black gray spot is gone because the cancer has responded to the platinum that's in the FOLFIRINOX combination therapy. We typically wait 4 weeks between the end of radiotherapy to bring the patient to the operating room for surgery to let the radiotherapy cool off. Now, this patient got COVID and got quite sick during that time. So while he was waiting, we put him on a PARP inhibitor, which also targets this type of tumor with the BRCA2 mutation. So tumor that's driven by a germline BRCA2 mutation. So this is just before bringing the patient to the operating room in March, and you could see, hopefully you can appreciate that tumor is not really visible. So the patient had a Whipple operation, or a pancreatic duodenectomy, in March 2013, and CPR means complete pathological response. There was no evidence of cancer there, and there's, I'm sure, others folks in the audience that have had similar experience. It just shows the potential and the effectiveness if we understand the biology and are able to target the tumors more effectively than with a one-size-fits-all approach that we've been doing for decades and haven't been able to make a real dent in the outcomes of pancreas cancer. So this patient is now 2.5 years out and remains quite well. So what about tumor profiling? Well, tumor profiling is primarily to inform us of treatments for the patient. It doesn't necessarily directly contribute to learning if this tumor was due to a hereditary cause, although it can. It's not the most direct way of doing it, but it can. And the recommendations now, and I don't know how well we're doing in Canada with this, but the recommendations are that for every patient with advanced pancreas cancer, have molecular profiling of their tumor right at the get-go, so that we learn and understand their cancer. We could start with first-line combination therapies, or best first-line therapy for the patient, but have an understanding of their cancer. So if that first-line therapy fails, perhaps we could, find a molecular change in the tumor that we could target, or even better, there may be a first-line clinical trial that the patient could go into and potentially have an advantage from being part of a clinical trial. So for metastatic, locally advanced or recurrence, when there's a recurrence of the cancer, the recommendation is to profile the tumor in addition to doing germline testing. What are the challenges that we've encountered and everybody essentially encounters with profiling tumors or from the pancreas? So taking a biopsy has incredible challenges from a pancreas adenocarcinoma, primarily because a characteristic of adenocarcinoma of the pancreas is that they have what is called this desmoplastic reaction. So there are very few tumor cells there. So a good sample is about 30%, but a good fraction, most of them will have less than 30% of tumor cells in the biopsy. So if we try to do high level profiling like we did for that COMPASS trial, we then have to somehow enrich our sample to be able to profile it. So we would have to use laser capture microscopy, for example, to collect all the cells and enrich it. So that's a challenge. In our program, whether it's on trial or not, if there's a metastatic lesion and we want to profile it at a deep level, and we will go after the metastatic liver biopsy. There's a little added risk, but the quality of the specimen obtained is such that we could go and do deep profiling. With respect to biopsying the primary, a little more danger to biopsy it, the primary percutaneously. And what we use, and most folks use, is a endoscopic fine needle biopsy. Fine needle biopsy versus fine needle aspirate has taken over now because it's a better quality biopsy that can be used to profile the tumor. Circulating DNA for pancreas cancer is an attractive concept and one that I'm hoping we could implement and develop the technology a bit better. The challenge for pancreas cancer to collect blood and identify circulating DNA that's been shed from the tumor is that these tumors tend to be very low shedding, so they don't shed a lot of DNA for it to be circulating and captured with the blood test and sequenced. So there's a reasonable possibility of missing some of the variants or missing some of the mutations from the tumor. Now, having said that, we know that if there's liver metastasis, if there's a high burden of disease, then the circulating DNA yield is much better and potentially informative, could inform and give us results that we could use. The other problem with circulating DNA that we have to be careful is what doesn't come from the tumor. So what comes from the blood itself, and some of the changes may just be clonal expansion of blood cells in circulation that are contaminants that we have to be careful in when we get these data and interpret it. What type of testing is recommended? So the testing that everyone pretty much does these days is testing for microsatellite instability, or another form of DNA repair defect called mismatch repair deficiency. And this is done by immunohistochemistry. This is more of a DNA and genomics test. Gene panel testing, RNA to look for what are called fusions, joining of two genes together or two transcripts together. In immunohistochemistry or in situ hybridization to look for HER2 amplification. This is done relatively routinely because it's easy to do. This is not as available as we would like it in Canada. And the motivation to make things available is if you have therapies. And, we do have access to therapy if there is this defect in the tumor, we potentially could access therapy if there's this defect in the tumor. But many of the other ones that are identified by a gene panel or by RNA-seq, we have more of a challenge accessing therapies, but also they're quite rare. So it's a question of where to invest healthcare resources. So how do I look at defects and how to target pancreas cancer? I have simplified it significantly for me to be able to remember this. So 80% of more than 80% of pancreas cancers do not have a targetable option today. In those, we'd like to have a clinical trial option. So even if it's a one-size-fits-all therapy, something newer that may have a better potential than what we currently have as mainstay therapy. And our mainstay therapies, what I have here is FOLFIRINOX, gemcitabine with Abraxane, gemcitabine alone, and there's some other less used forms as well. And then, there's our standard maintenance therapy. What everyone is excited about is the upcoming, pan-RAS inhibitors. So KRAS-directed therapy, because most of pancreas cancer was going to be KRAS mutated. Where, we talked about this, a prototype for precision oncology and pancreas cancer is germline mutations in the BRCA1, 2 genes and PALB2. This is quite clear that, and we do have access to therapies that we could target. If we know a patient has a BRCA1 or 2 or PALB2 mutation, we're going to try to pick a platinum rather than gemcitabine with Abraxane. Most treating physicians will. And then we also have the option of giving the patient in the maintenance, once we have disease control, giving the patient a PARP inhibitor that targets this defect in the tumor. If you have this mismatch repair deficiency or you have a very immunogenic tumor measured by tumor mutational burden, then immunotherapy or checkpoint inhibitors can be used. This is a very interesting group of pancreas cancers, those that do not have a KRAS mutation, which represent up to or maybe slightly less than 10% of all pancreas cancer. The reason they're interesting is they have some other driver. And quite often these other drivers like a BRAF mutation, a HER2 amplification, and some of these fusions, gene fusions, or measured by doing RNA sequencing of the tumor are targetable, and there are drugs available. So it's a very interesting group of cancers because they could potentially be targeted. But here's the challenge, and this is out of Kim Reese's review paper that came out this year, and you could see that once you remove BRCA2, 1 and PALB2, whereas this represents 5 to 10% of all pancreas cancers. Once you remove that, everything else is quite rare and doesn't add up to very much. So there are drugs. Some of them are accessible, others more difficult to access, but they're also quite, the frequency of finding these mutations or these changes to target is quite low. So where do you invest your diagnostics is something that a lot of institutions struggle with. Personally, I think it's such a difficult cancer to treat that we should be investing in these diagnostics. In Canada, so by and large, we have done this through research programs supported by the Terry Fox and program grants, and more recently through the Marathon of Hope concept. So I'd like to end, and this is a picture of some of the folks from my translational group by a patient's bedside. They helped profile this patient's tumor, and this patient went on to have a transplant. This is not for pancreas cancer, this was for cholangiocarcinoma, but really what we need to do more, I think, and I commend Craig's cause for putting this national conference together, because what you're trying to do is widen, and you're widening engagement and training. And I think it's important for us to do this as well in our own institutions at home. And within my program, we do that, try to bring the bench side into the clinical space as much as possible, and vice versa. All towards building a community and improving access for patients to be able to participate in precision oncology programs. I don't think that a single taxpayer system can afford all of this modern work and diagnostics. And this is where research helps bridge some of these gaps in our system. And so I think bringing the research side into the clinical space is quite important. Thank you. That's all I have.
Hi, Dr. Zagopoulos. We'll just see if there's any questions first before we move on to our next panelist. But I did have one question, which ties into the earlier session that I think maybe Jim could help with as well. So when we're using targeted therapies as an advocacy organization, do we have access? So when your patients present with a genetic mutation or require a more targeted approach, do you have access to those drugs suggested? And if not, how can we as an advocacy organization and partners that are all part of this conference today, how can we make that possible? And I agree when you talked about the single taxpayer funding. There's certainly challenges, but tying into our morning conversation about drug reform and funding, what are some of your suggestions or thoughts there?
I'd love to hear what medical oncology colleagues have to say about this from other parts, particularly other parts of the country. Look, olaparib for BRCA and PALB2 is available. PALB2 does take a conversation because it was not part of the New England Journal of Medicine study, but that's available, that's accessible, I think, throughout the country. Some of the others, they're much more rare and much more difficult to access. And it's a matter of advocating, showing some successes. I've spoken about precision oncology in a very positive way, but we haven't really measured an impact. We haven't really shown that it's truly affected lives and had a real benefit in survival. Part of it may be because we're using it in second line. We're not using it in first line. We're waiting until the patient has progressed and then trying to do it. So, after giving them 6 months, if not more, of cytotoxic therapy and all of the cumulative toxicity from that as well has an impact on their income. So I think for the most common form of targeted therapy, which is a platinum is part of the standard of care. It's just selecting one therapy over the other, and then PARP inhibitor, olaparib, that's available. I think it is accessible for most. I think where organizations can do and support is I think supporting drug is difficult, is expensive. Supporting diagnostics in the research space, as we've done in Canada, I think that's helped a lot in identifying patients that are candidates for these therapies.
So I'll make a comment from medical oncology. Thanks, George. Steve Welch here in London. So I think olaparib still is a problem. It's not reimbursed in Ontario. I have a patient who's doing phenomenally well with a BRCA2 mutation. She's metastatic disease, 3 years now on olaparib and thriving, and it's quite remarkable. But if she didn't have private insurance, she wouldn't have access to that drug. So that's not right. And this did go to well, not CDA at the time, in Canada, I guess, and it wasn't approved based on the randomized trial. So there's inequities across the country. We need to fix that. Olaparib is certainly the one that I think could be fixed, and sadly, we don't have too many other drugs in pancreatic cancer. But I think the point that you're getting to, because I'm definitely a big fan of molecular profiling when you can do it. We're looking for the diamonds in the rough. Because especially in that small group that is KRAS wild type, there could be a whole lot of really meaningful drivers. Unfortunately, drugs get approved based on trials in larger populations. So we're kind of looking at off-label use of these drugs that work in other situations. I think as a country, we have to think about how we're going to grapple with that. I know I just heard at a meeting yesterday at UHN. Princess Margaret has a research program of an N of 1 umbrella clinical trial protocol where, after vetting the particular biomarker cancer type, they actually get enrolled into their own clinical trial. They do this in the United States a fair bit. It is not done in Canada. That's, I think, something that really should be considered nationally of these sort of N of 1 situations. If we're going to capitalize on the promise of genomic sequencing to deliver on precision medicine, we can't forget, okay, yeah, we do this testing, but if there's no drug at the end of that rainbow, then what are we doing this for? So in my experience, because we don't have that, I'm ending up advocating, searching for compassionate access. Sometimes patients having to pay privately. You have to have these awkward conversations with patients, but I still think that it's the right thing to do the testing. And without that knowledge, you don't know how to go forward.
So if I could respond as well, Steve, thank you for that. I mean, I think, yes, I mean, I'm aware that in Ontario, olaparib is a challenge. Private insurance is a must. I'm sure there are other provinces that have the same issue. I think once you start testing and there's a big red dot around your center and your city, there's just going to be more folk that will reach out to their NPs and it will become available. I mean, it really did take for us, it did take that to get patients writing to their NPs and so on. And we've seen it with FGFR as well, where we've had to make a real push in Quebec to get that covered for cholangiocarcinoma, which is a sister cancer. So maybe, Stephanie, an answer to your question, if there's one thing to champion that will have potentially an impact, is what Stephen is just mentioned, is olaparib, get a PARP access to everyone in the country. Diagnostics are great, but you're right. If we don't have drugs, it's difficult. In terms of the N equals to 1, there are very clever clinical trials design that we could come up with. The problem is we cannot get pharma to give us access. And Stephen, you'll know this better than I do, as I don't treat with therapy. We just can't move clinical trials along. We can't open up arms. I mean, I think that's been a big challenge, trying to get pharma interested to share their pipelines for this patient population. So we end up, waiting for it to be done in other cancers, and then, as you said, borrow and steal evidence from other cancers to apply to ours.
And Stephanie, if you need somebody to advocate, I've got somebody who that drug changed her life. So yeah, I'll put her in touch with you.
Yeah, I think definitely there'll be some, next steps would be getting some strong partnerships together. I'm not sure who the next speaker is on the panelist is. Is it Rodney Ouellette? Okay, Dr. Ouellette, and I believe he's going to share his slides. Dr. Zagopoulos, thank you so much. And hopefully you can stay on just for the rest of this unless you're called into the OR. I appreciate it.
Are you seeing this?
Yes, Dr. Ouellette, we're good.
You're seeing it? Okay.
Thank you.
Okay. Good afternoon, everyone. Thank you, Stephanie, and the entire organizing committee for inviting me to participate. Unfortunately, I couldn't be there in person, but it's a pleasure to be here virtually. I have no disclosures to bring forward. Although I've done some work with pancreatic cancer in the past, research-wise, looking at liquid biopsy, I don't have an active program. So today I'm coming at this rather from my role as the director of the molecular diagnostic lab. And in reviewing this, I realized that a lot has changed since the last time I presented on molecular testing at this event. Only a few years ago, we were testing very few, if any, pancreatic cancer patients. Our assays were basically small targeted panels, and as a result, many clinically important alterations went undetected. Today, the landscape is fundamentally different. We have comprehensive tumor testing as well as clinical exome and whole genome sequencing, and we are now testing most, if not all, pancreatic patients. The shift is opening the door to a breadth of actionable findings that we simply couldn't identify before. So to give you some context, our laboratory here is at the Dr. George L. Dumont Hospital in Moncton. We serve much of New Brunswick as a regional molecular diagnostic lab. We're not a major academic center with active research programs, and yet we're able to implement molecular testing and bring advances when they exist into routine patient care. And while pancreatic cancer remains one of the most lethal malignancies we face, the number of therapeutic avenues are expanding slowly but surely, and creating opportunities for patients who had very few not long ago. So as was said previously, it's still a very challenging cancer. It's one of the deadliest cancers that exists. And optimization of diagnosis, prognostic setting, and treatment selection increasingly relies on comprehensive testing, including germline and somatic testing, to assess for actionable alterations. The different groups, NCCN, ASCO, ESMO, all recommend broad testing for pancreatic cancer patients. Forward. So germline testing, why test? There's approximately 10% of PDAC patients have hereditary cancer syndromes, even without family history. And the gene sets that are usually found in the hereditary cancer panels will include, as Dr. Zagopoulos said, the BRCAs, PALBs, ATMs, CDK, N2A, STK11, and the Lynch syndrome genes. And how do these findings improve care? As we saw, the BRCA and the POLB will predict platinum sensitivity and response to PARP inhibitors. It will also provide cascade testing potentially for relatives who could be high-risk individuals for developing this disease in the future. So they can be enrolled in programs that will help screen them as high-risk individuals. And prognostically, those same mutations will predict a better response to therapies like FOLFIRINOX. When it comes to somatic testing, PDAC has actionable mutations in about 20, maybe a little bit more, 30% of the patients that we test. And what's important as well, as it was discussed, is sometimes this can open the door for patients to be enrolled in clinical trials if they're out there. So some of the key actionable alterations, we discussed the BRCA and the POLB mutations. We sometimes find mutations in KRAS, specifically the G12C, for which there are targeted therapies that are out there. The BRAF V600 mutation is often, sometimes detected, and there are inhibitors for those alterations. I say often because we test all cancers, so we see the lung cancers and the colon cancers, and these are very frequent mutations that are found in other settings, and sometimes, fortunately, in pancreatic cancer. MSI and MMR or MMR testing can reveal patients that may be sensitive to immune checkpoint inhibitors like pembrolizumab. Fusions like NTRK are also something that can be picked up in these comprehensive panels. We can detect HER2 in the panels if there's enough cellularity. Otherwise, other testing using in situ hybridization is probably better adapted, or immunohistochemistry, as well as the NTRK fusions. There are also RET and ALK fusions. They're rare, but that are actionable. And TMB, tumor mutation burden, when it's found to be high, is also an indicator of benefit for immunotherapy. So, as was recently just discussed in the previous talk, MSI and MMR testing are very important. There are several methods to get to that information. The simplest is probably the IHC testing that's done in pathology, but similar information can also be obtained by NGS or PCR. When it's high, there's a very strong likelihood that patients will respond to this, and it's also an indicator of perhaps an underlying Lynch syndrome if it's done somatically before germline testing. RNA profiling is done as part of some comprehensive panels. I spoke of the fusions, the NTRK, NRG, as well as the ALK fusions. Some of these are very difficult to detect in DNA alone, so that's why adding the RNA component to the testing increases the possibility to find these variants. It can also can unlock opportunities in trials and determine resistance profiling in the research setting. Liquid biopsy is something that is not universally recommended, but it's something that's showing to have growing utility in pancreatic cancer. It can help us detect early relapse after surgery or systemic therapy. If patients are monitored while on therapy, it can help identify the appearance of resistance mutations. And it can also be a supplement or an alternative to tissue biopsy when tissue is scarce or difficult to obtain. Something that's being used more and more in labs. So, to summarize, how can testing improve patient care? Well, it allows us to begin to usher in a more personalized treatment selection for pancreatic cancer patients, be it with the platinum regimens, the PARP inhibitors, or immunotherapy. It allows us to make these decisions more with more knowledge in hand, so to offer these patients a better chance of success. Hopefully, in the future, we'll open up access to clinical trials, as many of these findings are used routinely in other tumor sites. So hopefully, that knowledge will migrate into the pancreatic cancer setting. Germline testing will help determine if other family members are at risk, so that more intense screening of high-risk individuals will help find the disease at earlier stages. And having all this information will help us, improve multidisciplinary management of pancreatic patients as they go through their cancer trajectory. So I'll stop at this. The take-home message is comprehensive testing is now standard in most places, and findings are guiding therapy decisions and assessing family members that may be at risk for the disease in the future. And hopefully, by incorporating this and continuing to move forward, we can improve outcomes and help integrate all this information into each patient's care pathway. I'll leave it at that if there are any questions.
Okay, do we have any questions for Dr. Ouellette? No. Okay. All right. So Orkin Hakars, you're next.
Okay. Good morning, everyone. Thank you so much to give this opportunity to me to present my presentation. Thank you. Thank you again to give this opportunity to me to present my presentation. Today I am going to talk about an oncofetal protein in PAN and the findings from Dr. Broad's laboratory. I also would like to go a bit fast because of the time restriction. Just a quick note about PDAC. So what is pancreatic ductal adenocarcinoma? It's the most prevalent neoplastic disease of the pancreas. The incidence of PDAC in the Western world is predicted to more than double in the next 10 years. Often diagnosed at a late stage when the cancer has already metastasized and treatment options are limited. Identifying molecular drivers of early stages could enable early detection and intervention. So here I just would like to give some brief about the research, developments, and research and treatment. This study was recently published about the use of personalized RNA neoantigen vaccines. So I am not able to give all the details because of the time, but the important part is that the use of neoantigens and each neoantigen is designed for each person. So it is a personalized approach, and it is claimed to delay recurrence. And as far as I know, this approach is now in phase 2 trial. After mentioning the importance of personalized treatment, the second important part is, or maybe the most important, is the early detection. A recent study claims about 93.7% of all samples were classified as PDAC positive or PDAC negative with 100% certainty using a serum biomarker signature composed of tissue inhibitor of metalloproteinase 1, intracellular adhesion molecule 1, cathepsin D, thrombospondin 1, and carbohydrate antigen 99. Is very important to detect the disease, and even actually before the disease development, it's really important to detect. So we ask this how we can detect very early. So if we look at here is a scheme about how PDAC is progressed. So you see the purple cell is a basically normal acinar cell in the pancreas. It actually keeps differentiated, and it turns to acinar to ductal metaplasia, ADM, and then if the KRAS mutation is also exists, it becomes persistent ADM, and if this process continues, we see a pancreatic intraepithelial neoplasia and pancreatic ductal adenocarcinoma as the last stage. So when we looked at human patient samples, we saw that IMP1 protein, which is an insulin-like growth factor 2 mRNA binding protein, is highly expressed in ADM and also is expressed in PDAC. So in my project, I looked at the role of IMP1 and identify downstream genes. So to give a brief information about IMP1, IMP1 is a protein that stabilizes mRNA. So you can see in the little red circle, IMP1 is binding mRNA and then makes mRNA highly stable, highly resistant to stress, and it is found in PDAC, can be found in cancer development. We actually inhibit this using a drug, and then we use pancreatic ductal organates bearing the oncogenic KRAS G12D mutation. So here you see the oval structures. They are organates. They are grown in tissue culture in a plastic tissue using a matrigel. This gives a three-dimensional cell culture approach. And we inhibit in these cells, we inhibit IMP1 and then look at the whole transcriptome change. So if these are inhibited by if IMP1 is inhibited, how the transcriptomes change can be seen. So actually there are a lot of steps, so I don't give all the details, but once we have the genes of interest, we went for functional analysis. So here is you can see the results from the big data is basically you can see the green dots are representing the drug used group, IMP1 inhibited group, and CC40, the red dots represent the control group. So the data profile was clear that these groups are very different. And some of the enriched biological pathways were found related to cancer, which are highlighted here in red color in the table enriched biological pathways. And on the right is the heat map, and it shows differential express genes between this VT20 containing group and control group. We found two genes really important and highly downregulated. One of them was gastrokine 3 and the other is IL-13 receptor alpha 2. And then we use gastrocantry protein and IL-13 protein on acinar cells that are isolated from mouse. So it is called ex vivo. And then, so for those acinar cells, we add TGF alpha, which is the positive control, and gastrocantry or IL-13. And you can see actually this is showing good. When you add vehicle at the top looks small, and then TGF alpha is a positive control. The structures are grown or expanded more, and then the ADM events are clearly seen in the third, that the structures are really grown bigger. For here, we implemented an AI-based approach because we had lots of images, over 1,000, and each image has many many structures like you see here. So and we were able to deal with the complexity. So I also look at which biological processes can be seen in this big data, transcriptome data. It's actually, there are many biological processes are going on, but I was able to simplify it using a binary cut method, using a bioinformatics method. And you see there are which responses are seen. And it's interestingly, we noticed the immune responses, chemotaxis. So we should also think the immune responses are heavily involved in this process. So then we silenced IMP1 in PDAC cells. We used two cells, which are LMP and KPC46 cells. And when you look at the metastasis per liver are decreased in the IMP1 knockout groups. So this is the mouse study. Each mouse were injected with these cells through spleen, through the spleen. So the second image is a representative. There are more lesions in the parental and control, whereas the lower lesions in lower number of lesions in the other groups, which receive IMP1 knockout or IMP1 silenced cells. And the size was also reduced in the KPC46 cells. So then we asked about, can this be a biomarker, in the role of IMP1 as a biomarker? We first used the mouse model. The mice we used received serine to develop acute pancreatitis in the mouse. And you see the arrows actually show the ADM events. And then the plasma was taken and processed for nanoparticle tracking analysis, and extracellular vesicles in plasma were detected. And in the control, we didn't see the presence of IMP1, but in the serine injected mice showed a good level of IMP1. Also, TCG101 we used as a marker of exosome. So then the last step, we looked at this, whether IMP1 is found in plasma from PDAC patients. I'd like to thank to Dr. Zogopoulos, who provided to Dr. Broadlap these samples. And when I looked at the IMP1, I noticed that the 5 patients had this IMP1 presence. So here is these are Western blot, and P2 is early stage compared to the others, more early, and it was actually more expressed. But of course, the number of samples not many, but still we were able to see the presence of IMP1 in plasma, and it is also variable, which actually reflects our findings, previous findings in the tissue or other experiments. So again, if you remember the slide, the study about serum biomarker signature, I checked that is there a relationship with IMP1 and the proteins that are used to detect PDAC1, to detect stage 1 or stage 2 PDAC, and IMP1 appears to be related with cathepsin D and metalloproteinase. So as conclusion, we identified a transcriptome profile associated with early stages of PDAC development and regulated downstream of IMP1. Targeting IMP1 and downstream regulated genes may have important clinical implications, particularly for patients at high risk for developing PDAC. The role of IMP1 and its transcriptional targets is currently under investigation. We are working on now to develop innovative genetically modified mouse models, and we will investigate the role of IMP1 and the transcriptional targets in this model. I'd like to thank Dr. Broadlap, Dr. Grigoriev Lab, Dr. Lowy Lab, and Dr. Zagopoulos Lab. I also would like to thank the members of these labs. Actually, it's very important to work with different labs and to integrate multidisciplinary approaches to be able to reach some important and translational results. Thank you very much. So.
We're almost back on track for time. I do have one question for the entire panel. So we understand the importance and the opportunities of integrating molecular profiling and liquid biopsies to improve personalized treatment. But one of our learning outcomes was speaking to some of the challenges. So we've talked about funding. Would you say access, patient access to this would be challenging? Are there any other challenges that you find?
Yeah, so particularly like a personalized medicine part, I think is important. But I don't know how clinically and how practically actually is available everywhere. That's the one thing for. So I think the developments in research is more on personalized medicine, I think. And also for that, the detection is very important before the tracing symptoms. I mean, so it's more, must be acted very early. And if it is detected very early, I think personalized approaches like mRNA vaccines nowadays are, I think, very promising.
Stephanie, I think that's an excellent question. I mean, I would take a step back and look at what's ready for prime time and see how we're doing. Not to harp on germline testing, that's just easy. It's inexpensive relative to other things. Every patient could have it done. It could even be done by remote phlebotomy, and returning that, has a significant impact, not just for the patient potentially, but also for for their relatives. Making the argument to access olaparib, I mean, if we identify patients and show that there's a concentration of patients that would qualify for it, I think makes a stronger argument to get payers to pay for it. So I think, I'm not sure how well we're doing with germline testing. And I'm basing that on our own experience. When we pulled the research group out of the clinic space and mainstreamed it through oncology, we saw a significant drop in the number of patients that were getting germline testing. It's only once we did that as an experiment, and now we provide that facilitating for testing. So I think the germline testing probably is still not benchmark where it should be to have an impact. And then the other part I would say in terms of tumor profiling, I mean, Rodney, I'm very impressed that you're able to offer all of this for every patient, because we don't. We're selective. We will do IHC for mismatch repair deficiency, and then be very selective with other things. Primarily, hard to justify a panel right now if we don't have access to drugs, like what Stephen said earlier. Liquid biopsies, I think that's still in the investigational space. The shedding is quite low. I'm not sure how to interpret liquid biopsy for pancreas cancer, to intercept a recurrence. I really don't know how to interpret that. So I think that's investigational more than anything.
George, I may add just a caveat. I mean, we sequence all the samples we receive. So not being on the front lines, I don't know if we're getting every pancreatic patient sample. So there's no filtering once we do receive it. And for us, the germline, I would say it's kind of the opposite. The somatic will trigger us likely germline, and then we flag it. It goes to the oncologist or medical genetics, and they will do the germline afterwards. So it's kind of the opposite way around here. I don't know if it leads to more uptake. I'd have to pull the numbers to see how many we've done, but it's somatic first, germline second.
I'm wondering, with our pathways, that the diagnostic pathways, what we should be. I'm wondering if we should put in germline or specifically, like, is that a standard that we could get across Canada? It's a hard question. Yes? Yeah. We have someone in on Zoom. If you want to unmute, I can't. Your name's too tiny at the top of the screen. We'll see if we can get.
Yeah, thank you.
Yes, go ahead.
Perfect. My name is Carol Kremen. I'm a genetic counselor in BC at BC Cancer. And I just want to highlight that point. So critical that regardless of where you live and your age at diagnosis and clinical features, that really this hereditary testing is key to advocate for. And so it comes a little bit to your point about pathways, and to George's point about it being kind of straightforward generally in terms of a blood test. In BC, we are measuring uptake of this testing and really trying to understand more what the gaps are. So what groups are not being served by this testing or are not accessing it through their providers. We've really tried to open that door up with respect to mainstreaming so it can be offered by any provider. And we've tried to improve the educational resources on our website, access to the requisition, how to do the testing, a pre-test information sheet. And I think it has streamlined things, but we still need to make more improvements, especially in the primary care space. So I think a little bit tying back to the last panel discussion around GPs and NPs also feeling comfortable, ordering this test. And in our program, anybody with a hereditary finding is automatically referred to the hereditary cancer program for follow-up, and that critical piece about cascade testing for relatives. So trying to then, move that journey a different direction for their close relatives who carry the same pathogenic variant. Yeah, so just if if you're a patient and you have pancreatic cancer, really make sure that you advocate for getting that germline testing. And if you're in BC, you hopefully have had it done, and if you haven't, we should connect after. Thank you.
I know that in the States, in PanCan, in the Rolf Foundation, they have, I think one program's called Know Your Risks, and one is Know Your Family, where those advocacy organizations have a document that, or an online form that the patients fill out. They submit it back to the organization, and the organization has a partnership that can get back to the patient to say, yes, you do have these risks, and you should monitor and advocate for screening and maybe genetic testing. And it's certainly, a project that we've been looking at in the coming year as well. So I don't know if that would help with the process or not, but. So I don't know if there's any other, Erin, is there any other questions in the Zoom? No? So your lunch is not cut too short. So I want to thank our presenters, George Orkun and Rodney. Thank you very much.